I'll be presenting a study of a real-world analysis of Brexucabtagene, autoleucel, brexu-cel, and relapsed refractory mantle cell lymphoma. This is a CIBMTR analysis, and we looked at both overall real-world safety and efficacy outcomes of brexu-cel and relapsed refractory mantle cell lymphoma, and also looked at safety and efficacy based on prior treatment. This study consisted of 380 patients across 84 centers in the United States, and data was collected over 2020 July to December 2022, and all the data was extracted from the CIBMTR registry database. We had a median follow-up of 12 months, and in the overall patient population, we found an overall response rate of 90% and CR rate of 78%. In terms of safety, we found overall any grade CRS of 88% and ICANS of 68%, but high grade 10% and 28% respectively. I think what's exciting about this study is that we included a heavily pretreated patient population in this real-world analysis. Median prior lines of therapy were 4 and ranged from 1 to 12, and included patients with high-risk adverse features, including 20% of patients with TP53 deletion, I'll repeat that, 20% of patients with TP53 mutation and 17p deletion, and 44% of patients with high Ki67. So this was, again, a patient population that had high-risk features, 6% with extranodal involvement, and included patients who would not have been eligible to enroll in ZUMA-2, so reflecting a more real-world practice. And so at this 12-month follow-up period, we're seeing pretty comparable safety and efficacy outcomes to ZUMA-2. One of the big objectives of the study was also to evaluate these outcomes based on prior treatment. And in looking at the subgroup analysis, we looked at how does the impact of prior BTK inhibitor exposure, prior Bendamustine, prior autologous stem cell transplant, and prior lines of therapy affect both efficacy and safety. So in this subgroup analysis, where we evaluated outcomes of impact of prior treatment on efficacy and safety, we used a multivariate logistic regression model. The model is adjusted for age and sex and many other baseline characteristics to minimize confounding factors. We found that exposure to prior BTK inhibitor and Bendamustine did not really significantly impact the efficacy and safety outcomes. Patients who had received prior transplant had improved PFS. Patients who had received prior Bendamustine had reduced rate of high-grade ICANS and prolonged thrombocytopenia. Those who had received brexu-cel in 1 to 2 prior lines of therapy compared to 3 or more had twofold higher odds of achieving CR and had overall higher response rates. These patients did have an increased risk of high-grade CRS. So this study, I think, shows, again, the real-world outcomes and safety looks comparable to ZUMA-2, but I think we need longer follow-up to see how durable these responses are. We also need a larger sample size in some of the subgroups, such as the BTK-naive cohort, but I think it's an important data as the ZUMA-2 study only enrolled patients who were exposed to prior BTK inhibitor. This is the largest real-world study to date, and I think with more follow-up and even more sample size, we can further validate these findings. And I think in the future, we'd also like to look at more granular details, such as timing from prior Benda to CAR-T infusion, as our study did not suggest that prior Benda is affecting the safety and efficacy outcomes, but we'll need further exploration of that.